Thanks for coming to CCHF and to this workshop titled Got Pharmacists, Embedding Clinical Pharmacists into Primary Care. This session's approved for credits, so Javilla's going to talk a little bit more about those credits.
Yes, so guys, if you want to get the CME, CDE, and APCP paperwork, you will go downstairs at the registration desk and talk to the awesome people there, and they will do the rest of the miracle. And so today we have Dr. Sarah Love and Dr. Sue Paul, so let's give them a warm welcome of applause. Sorry.
Hi, everybody. Can you hear me okay? Okay. My name is Sarah Love. I'm a family medicine OB. I am, almost 4 years out of residency training. I have a bunch of different roles in my job. I'm on faculty with the UC Christ, so University of Cincinnati here in town. Family medicine residency on maternity care faculty, so I take care of pregnant women and do deliveries and take care of newborns. And then I also work over at Crossroad Health Center, which is the local CCHF clinic, and I'm the women's health director there. Here's just a little bit about me. I think one of the reasons I went into family medicine and work at Crossroad is because I want to provide care that's honoring to God, to care for people's mental health, spiritual needs, physical health, and just provide compassionate, equitable care. So,
Can you hear me okay? Okay. So I'm Sue Paul. I've been in practice almost 4 decades versus 4 years. And so I have done the whole thing. I went from retail to nursing homes to hospital to Coumadin clinic, and discovered or realized that America's over-medicated, and I wanted to be able to affect change and decrease the amount of medications that patients are on. I especially saw that in my nursing home practice. Patients were over-medicated. I kept thinking if somebody had gotten to the patients or a pharmacist to review the meds, they probably wouldn't need this level of care. So my journey has been a true faith journey, and I kept wondering that for 16 years in the nursing home, somebody should do something about this. And then God kicked me off the ledge and said, that's you. And so what I did was I created a business and started contracting with primary care providers to be able to do that. So I'm a mom with 4 kids, 4 adult kids, and I love to connect with others. And I'm so grateful that Crossroad has been part of my journey. I've been there 8 years. So I think a lot of FQHCs are the same, where we have a collaborative care team. At Crossroad, we have a diabetes educator. I'm currently working on my CDE also. Behavioral health consultants, and myself, a clinical pharmacist. We have 5 locations. I work at 3 of the different sites, so I work a different place every day. And then I spend 2 additional days working with the homeless population. So my role at Crossroad has been, I see patients, I have a schedule. A patient will come in, they're uncontrolled. The provider will put them on medication and bring them back to see me in 2 to 4 weeks to either get labs, tweak the meds. And so I do diabetes, pre-diabetes, hypertension, hyperlipidemia, asthma, COPD, MAT, smoking cessation, Coumadin therapy. Recently took on treating Hep C patients, and then preventative health, like making sure people are getting their colon cancer screenings, mammograms, and things of that nature. I also work on a lot of the prior authorizations. Raise your hand if you're a provider in the room. Yeah, worst, it's like the worst ever. Aren't PAs, or maybe not, I don't know, maybe you like them. But I take that off the provider's plate and either just go ahead and switch it to whatever the therapeutic interchange formulary preferred med is, send in the script, or I go ahead and get the prior authorization, which I'm not gonna lie, I'm pretty daggone good at. GME forms, I help a little bit with that, refill requests, and then of course any medications that medication questions that come up. So in general, having a pharmacist on the team is a different perspective. It's kind of a medication perspective. And then I do a lot of lifestyle coaching and training. I get 30-minute appointments, and then I see up to 14 patients per day. And that's basically it. Like today, I had a patient in the office. His A1C was 11.9 last month. Brought him back. He's trying to get his ODOT registration, but he can't because his diabetes. He's a trucker, and he's not approved because his diabetes is not well controlled. I slap a CGM on pretty much anybody. Right now, we primarily use Freestyle Libre because we have more access to those. Best friends with the rep. So this was a self-pay patient. He's on metformin and Victoza because that's available on our 340B program. And he's gone from 11.9 to 10 in 4 weeks. So just having that awareness and then the diet education, it's been pretty amazing. When I looked at his Libre view today, so I don't know if you're familiar, but I can see what his sugars are trending. He's been in range, and his range for diabetes is 70 to 180, 93% of the time in the last month since he got his Libre. And his A1C is trending towards 6.6. So it's good. I printed that off for him to give to the, is it ODOT? What is that? For truckers? Yeah. Whatever it is. So my goal is to deprescribe whenever possible. My favorite days are taking patients off insulin, just by giving them the tools so they can better manage their chronic disease state. Whether it's a blood pressure machine for blood pressure issues, hypertension, or a CGM, that's my perspective. And I tell the patients, medications are important. I feel like they're a bridge at least to get you from where you are to where you're going. And if you can make the changes, I need you working hard and I'll work hard for you. And this is how we're gonna manage it. Some of the providers have mentioned that it decreases their burnout because they're sharing the load of those more complicated patients. So basically they'll see the patient every other visit and I'll see them every other visit and tweak and such. Sorry, I can't see it with this one. It also takes off some of those administrative tasks like the prior authorizations and such. And then I do go through, like for example, if you were to order a Freestyle Libre, sorry for the brand name, but if you were to order a CGM to the pharmacy, the chances of them getting trained on how to utilize that and how to best get the use that information appropriately is pretty slim. It may or may not happen, but probably not. So I walk through make sure they know how to use it, tell them if their sugars are over 200, let's drink some water and do some physical activity to get the muscle out of your bloodstream into your muscles. So it's been really helpful for us. I also work on making sure patients can afford their medications. I work with the 340B pharmacy a lot. We currently have a contract pharmacy. I'm just gonna mention this. So I work at the homeless clinic 2 days a week, and we opened our entity-owned pharmacy yesterday. They had tasked me with opening a pharmacy. So it finally opened yesterday. And that clinic is a 340B clinic that serves the homeless population. So by improving our outcomes and measures, we are beneficiaries of some of the value-based monies that the insurance companies are saving because patients aren't going to the hospital and their numbers are improved. So this is just a basic hypertension appointment. I'll sit down with the patient. I do MedRex with everybody. And if I can see in their face that they are not getting it, I use the sync. So I say, put it on just a regular level and say, this is how we want your blood pressure, and then I turn it on high. This is where yours is. And so I just use what's in the room, and then they kind of get it. And I'm like, I'm not trying to make you uncomfortable and take medications and stuff, but right now we need to get this under control because this is affecting your kidneys and your brain and your heart, and we're trying to prevent stroke or heart attack. I do make sure that they have compliance tools and the blood pressure machines and then medi sets and such so that they know how to take their medications. Okay. A diabetes appointment. I don't do it as much anymore. I used to have the a tomato paste and vinegar where the viscosity was what your sugar looks like at 100, 200, and 300. Now I just use what's in the room. So I'll turn on the sink, that same just regular stream, and say this is what your blood sugar looks like at 100. I'll get the alcohol sanitizer. This is what it's kind of looking like at around 200, and then I get a thin lotion and say this is kind of what it looks like at 300. And so this is why we want your diabetes under control, because that's affecting your kidneys, heart, brain. You may feel sluggish, yada, 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 yada. All right. I also do pharmacogenomic testing. Does anybody use genetic testing, pharmacogenomic testing at their practice? We found it really helpful for our patients with mood disorders. And so this is just the basics of pharmacogenomics. I'm sure you recognize that not everybody responds to the medications the same way. And there are some genetic enzymes, liver enzymes, that we look at that are mainly responsible for metabolizing the medications, that we can see if there's any variance in their genes and then get them on the right medication. Here's kind of an example, and please stop me if you have any questions. Yes?
How much does that cost?
So for our patients, the company that we use, there's no cost to our Medicare or Medicaid patients. If they have sliding scale, if they have commercial insurance, they have a sliding scale fee, which is very generous. I think anything below $74,000 is maybe no charge for the patient or a minimal charge. It goes up to $349, I think. And then we typically don't offer it or use it for our self-insured or self-pay patients. We try and get them hooked up with insurance, and then we order it. Yes, I know. The insurance companies rule the world. So this is kind of what we'll get. We get green, yellow, red. Red doesn't mean that we can't use it. It just gives us some more dosing information. The patients love it. It's been incredibly remarkable how well they improve once they recognize that we are personalizing their medication. So one of the secondary outcomes that I have noticed from this, they start taking all their medicines because they know that we're trying to work with them. We didn't put any case studies for PGX in here. Is there anybody you could think of that it was helpful?
I'd say I was a little bit hesitant. When I did my residency training, I did not do this at all. So my first year or so in practice, I didn't really do a ton of it. I'd say I've been ordering a lot more of the pharmacogenomic testing for mental health for a variety of reasons. This basically tells us like gene-drug interactions rather than if this is in the green, it's definitely going to work for you. So if you see some of the more like expensive medications on there, like Trintellix doesn't really have any gene-drug interactions, that's going to always be in the green section. But there you go. And they have it separated out by antidepressants, antipsychotics, etc. I would say, I think I don't typically do it, like I typically start somebody on an SSRI for depression, like if they're SSRI naive or if they've done well on one before, but it's when we start getting into like multiple drug failures, if I'm at the point where I'm thinking, okay, I need to send this patient to a psychiatrist or do something different. Sometimes this can be helpful to kind of help tailor it. I think it's most helpful for people who have a lot of side effects with medications. Oftentimes it's because just how their body metabolizes the medication, they just have a lot of side effects. So being able to choose something in the green or even in the yellow category, but like, higher or lower dose can be helpful depending on what it recommends. And then another thing I've seen, sometimes you have patients that when they were a teenager, they were put on a bunch of medications, felt terrible, came off of them, and have dealt with severe depression, PHQ 9, 22, and just sludging along because they're afraid to take medication. There have been several times in which I've offered this test just to be like, hey, why don't we just learn more about how your body metabolizes medication? And I've had people be a lot more open, not everybody, but people be a lot more open in that kind of demographic to trying an SSRI if they know that their body's gonna metabolize it in an appropriate way. So I find it helpful. I don't use it on every patient, but yeah, and I haven't had anybody complaining about any large fees. I would say that just being at an FQHC, we don't really have many people that are having to pay anything for it because Medicaid and Medicare cover it, and then I don't think we have many people making more than $75,000 a year that come to our practice. So.
Do you find that you have less pharmacies or less pharmaceuticals being rejected because you've done
That's
this?
a good question.
Yeah, so
Yes.
that's a great question. I will, if I need a Trintellix or something like that, something off the wall, I will send in the results and get it approved. This is what they failed. Here's their test report. This is why we're picking this med, and get it approved.
So you use it in psychiatry. Why don't you use it in other indications?
Yeah, so there are some benefits in cardiovascular, respiratory, many other disease states. The reports are, this report is 8 pages long. The reports can be 40 plus pages long. And if you're really only looking for one certain thing, and I can take this information from the information that's in there and extrapolate it to like a CYP2C19 for PPI or clopidogrel or something like that. I do use another test that does have all that, but what I've heard from my providers is they don't want all that information. It's too much to dig through, yada, yada, yada. So that's why I don't.
You have information on the
Sure, yeah. Yeah. Anybody else have any questions about that? They've done some studies. One of my, what do you call it, side gigs, I teach pharmacogenomics, the science of it, to providers, healthcare providers. It's a 20-hour continuing education course. But the benefits that they've seen through some studies are reduced hospitalizations by 39%, emergency room visits by 79% in elderly patients. I first started using this when I was in the nursing homes back in 2016. And so we were able to get them on the correct medication when they needed to take it. On home health patients, they found that using multiple medications, they reduced readmissions by 52% and ED visits by 42%. I think we're finally, I've been doing this for a long time, we're finally hitting a tipping point where this is becoming more of a standard of practice. There's 26, 27 guidelines right now. CPIC is the resource, cpic.org, and there's lots of big words in there so that are leaving my brain at the moment. But you can check that out for the guidelines. Benefits, so providers have a more patient-specific list of medications to choose from. And then patients see better benefits, and they're more engaged in their health. They trust their provider more. And then, like I said, also, their other medications seem to fall in line. Some other opportunities for using a pharmacist in the office, transitions of care. There are codes if a patient is released from the hospital where a non-provider can follow up with the patient within 7 to 14 days and be reimbursed for that touching base with them. Chronic care management, 20 minutes per patient per month. I believe the reimbursement's about $42, non-face-to-face, but touching base with them, checking to see how their blood pressure's running, diabetes, how their sugars are doing. Cancer screenings, the preventative health that we already talked about. I've run group diabetes programs, creating a new one at the moment, hepatitis C clinic. So that is something that we've really embraced. I received 2 today from a provider to check into, and basically the provider gets the labs. If they're positive for hep C, then I will get additional labs and then check for the drug interactions, send in the prescription, talk with the patient about adherence and the expectations that are coming. And that's a great moneymaker for a 340B pharmacy. Yeah, it pays for my salary for sure. And then medication affordability. If a patient's having issues affording their medications, pharmacists can probably figure out what is more cost savings wise. So this all sounds great, doesn't it? How are we going to afford a pharmacist in the office? And so what they have told me at the C-suite is they get grants. They put my name on every grant. The 340B monies that come from our contract pharmacies. And then my visits are billable, 99213, 99214. I currently do mostly shared visits, so I also have a CPA that we are starting to utilize where I would be doing up to a 99214. And then the COO said, I'm worth every penny. I just had to mention that. And the CFO said, I think one of the best, the one-on-one care with the patients is the best benefit. And you know, he's a numbers guy. He doesn't have very many feelings. So for him to say that, it was kind of heartwarming for me. Okay, maybe he has feelings. Our UDS measures, you can see they have been improving every year. For example, at the bottom, I know this is hard to see, but back in 2020, we had 30% of our patients had an A1C over 9 for diabetes. It got down to 22% in 2022. It bumped up to 24%, but we also had 150 new patients who had A1Cs over 9. So we are actually attracting more patients because of the care that we're giving, and they're telling their friends, and they're telling their friends and family members. So hypertension is a similar story. We're at 70, we were around 59%, and now we're at about 71% in 2023 for controlled hypertension, which is less than 140 over 80. Our depression screens are improving. Tobacco, I address that at every visit, as do the other providers. This is team-based care. I'm just a vessel, but being on the team and working with these amazing providers, our tobacco screenings are over 90%. This study was from 2001, 2005, and they said the ROI for clinical pharmacy services was $4.81 for every $1 invested into employing pharmacists. Here's a patient. I have her signature. She was actually in the office yesterday. She started off with us back in 2017 with an A1C of 12 on insulin and all the things. And yesterday she was in the office. It went up a little bit, 6.7, but she's only on metformin and Victoza anymore. She said it's wonderful to have a pharmacist in the office. She said, I'm more comfortable talking to a pharmacist than an MD. You helped change my mindset and showed me I could change the outcome of living with type 2 diabetes. You were also instrumental in helping decrease my medication costs. The most expensive medication is the one the patient can't afford, you know, or the ones they don't take. It just is bad all around. And then, does anyone have any questions for me before I turn it over to Dr. Love? Yes.
Are you a team of one, or do you have a team in your health center? What is that?
Yeah, I'm a team of one. I'm working on hiring other pharmacists to expand. I had hired one before I took on the homeless clinic, and he got his dream job. So anyway, at the moment, I'm still a team of one, still on the lookout for another pharmacist to train and help me out. Yes.
This, like, scope of care of a pharmacist, does it vary a lot state by state? Or, you know, like what you're able to, if you're able to prescribe and like make medicine adjustments?
So her question is, scope of practice, does that vary from state to state? And does it matter about prescribing and billing and that type of thing? It does vary from state to state. I have a pretty comprehensive CPA where I can do the Hep C and mood and those types of things. But not all pharmacists are comfortable with that. You know, my goal is, my dream would be to train pharmacists and put them in CCHF FQHCs all throughout the nation. That's kind of my big, hairy, audacious goal. But we'll see. I'd be happy to talk with people if you prefer or would like to afterward.
Okay. I'm just gonna see if I can hold those. Okay. Well, I'm gonna go through some patient cases of some mutual patients that Sue and I have worked with together. This is SH. So I've been at Crossroad for about 3.5 years now. So I met her soon after I started at Crossroad, and she had been at Crossroad for a couple of years at that point. At that point in 2020, she was a 44-year-old female. She had poorly controlled diabetes, hypertension, hyperlipidemia. I guess she was initially seen in 2019, and she hadn't been seen for a couple of years because she didn't have health insurance. And during the course of like that period of time when she was seen by the previous doctor and before I started at Crossroad, she ended up being diagnosed with endometrial cancer, actually at Crossroad by that doctor, and was just so focused on that, like the diabetes kind of took the back burner. And she also lost medical insurance, and it was just kind of a difficult place for her to be. So these are all of her diagnoses here, also depression, anxiety, and then in her younger years also dealt with opioid use disorder, but not currently. You're fine. So when she came in to see me, it was at some point in 2020 after I had started at Crossroad. She had been off of her medications for a while. Her A1C was at 13.6, and put her on metformin and on low-dose dulaglutide with the plan to titrate both of those up. At that visit, I mentioned insulin to her as an option, just with her A1C being so high, and it had been in like above 10 for like, I don't know, I'm sure years at that point. It was above 10 when she came to us in 2019, and she was off of meds prior to that. And she was really wanting to be able to improve her glycemic control with medication and diet control alone. So like many of you guys know, even if we schedule follow-ups and make recommendations, people don't always come to those appointments. So my plan was for her to see Sue a month later, but she did not come in, and we just kind of waited for her to come back. So almost a year later, she came in, and her A1C was still at 13.6. I also take care of her younger daughter who is adopted. It was somebody in her family's biological child that she ended up taking in. So she's dealing kind of with the stress and all the roles of that. And then also she traveled a lot for work and was eating out a lot, and just had a hard time coming in to appointments. So I resumed the medications again. I said, let's titrate up. Please come back soon within the next month. Okay, let's see, was this the next month? Oh, the next month, she actually made a decent amount of changes. I think she just needed to get on some sort of medication. It was down to 11.9. Sue provided her dietary counseling, performed a diabetic foot exam, and then got her a Libre, which is honestly what the game changer was. One of the things I love about working with a pharmacist is I don't have to know or do everything. We only have so much time in appointments. We're allotted 20 minutes for a visit at Crossroad for our standard patients. And I don't have time to deal with all of their problems and teach them how to use the Libre and do all these things. So having her follow up with Sue to teach her how to use the Libre, that's actually a requirement that I have. I'm like, if you get a Libre, you have to meet with Sue so she can teach you how to use it. Because I know she's going to do a better job than I will, and she has the time to do it. And I really like what you said about decreasing provider burnout. It like in these patients that have poorly controlled chronic conditions, it can be kind of draining as a doctor to kind of say the same thing over again or feel like you're not making a ton of progress. So I feel like I have a lot more joy in my work being able to collaborate and care with the patients, like with a pharmacist, because we share visits. Like we alternate visits. Whenever Sue sees one of my patients, like I also go in and see them at the end and kind of confirm the plan with them and see if they have any other questions. But it makes my job a lot easier. So at that point, she just was not tolerating metformin super well, so we're not titrating up very good on that, but increased up the dulaglutide and then started her on the Libre. Came in, I guess, 6 months, 5-6 months later, 11.2. She was not consistently taking her medication. And then was having a bunch of GI side effects because she was only taking the metformin intermittently. But I guess 3 weeks leading up to her appointment, she was like, okay, I'm going to come in and see my doctor. I should probably start taking my meds. And she was actually doing really well. I think it was just the intermittent nature of the intermittently taking the metformin was the problem causing her all those side effects. At that visit, we decided if your A1C is not below 9 in 6 weeks, we got to start insulin. And she was scheduled with Sue for that visit. We increased up the dulaglutide again. And let's see. Let me see. Yeah.
You must have taken it out.
Okay, it was not 8.2 yet, guys. I'll just tell you what happened. She agreed to start insulin at this visit. We started on 10 units of insulin glargine. And she came in a month or two later, I think, 2 months later, and her A1C was down to 8.2. So this was January of this year. And at that point, we ended up increasing the dose to 20. The thing that was most exciting to me about this is this was a patient that had been seeing us for a couple of years and just was not very engaged in her care. She was super overwhelmed caring for her daughter and all the social stuff that came along with having an adopted child, and she was traveling a lot for work. So she just wasn't super engaged in her care, was always putting everybody else's needs above hers. But at this visit, she was like, you know what, I can actually see what's going on with my blood sugar. And I'm really excited that my blood sugar is coming down and having a high amount of time in range. In this period of time, she referred her sister and her aunt to me. So I got 2 new patients, both of who have diabetes, and SH has been teaching her aunt and sister about how to control their diabetes and telling them they need to take their metformin every day so they don't have GI side effects. And it's just been a total game changer. And I really think the extra time that Sue is able to spend with her, having more than one provider involved in her care that cares about her, and then honestly the Libre, her being able to see what her sugar's doing after she drinks a big gulp made a big difference. So. And then you know what? Let's see. She was supposed to come a week ago and didn't, so hopefully she's doing well. We were hoping to have a very fresh update on her. So
I could probably look her Libre view up.
You probably could, yeah. So things aren't perfect yet, but she's heading in the right direction. She had a decent amount of weight loss, and then was on lisinopril for hypertension. Got her hepatitis B vaccine. So, and Sue's not just doing diabetes and hypertension, she'll do mood follow-ups, she'll do diabetic foot exams. The PAs is the best part, guys. I hate PAs. I think most people do. So I really appreciate her being able to do that. She's also a lot better than I am at filling them out, so she tends to get a lot more medications approved than I do. So, because you don't learn that in medical school or residency. So, okay, we can move on. Does anybody have any questions about SH's case or kind of how that played out? Okay. Okay, I have one more case for you guys. This is JT. So he's a 50-year-old female. He had been, male. We have one female, one male, that presented to Crossroad Health Center. He was seen at Crossroad for a couple of years before I started there. I took over his care in 2020. And At that time, he was being followed for hypertension, chronic kidney disease, and then when I took over his care, I noticed he had some elevated LFT, so I was doing a workup on that. He also has bipolar disorder and is managed by psychiatry. He was on a bunch of different medications, including lithium at the time. Because of his CKD3, his psychiatrist took him off the lithium and switched him to Seroquel. And these are all of his diagnoses here. The big thing that we're planning to talk about today is the alcohol abuse, which is something that he never really wanted to talk about. It took a long time of getting to know him for him to start feeling comfortable to talk to me about that. But within a couple of visits, I kind of realized most of his problems were rooted in his alcohol use. You can see here Barrett's esophagus, constipation, erectile dysfunction, his blood pressure being high, fatty liver disease. I kind of just kept on seeing him and seeing where he was at. At that time, I guess March of 2021, he had an ultrasound that showed fatty liver disease, and I suspected it was from chronic alcohol use. And then his creatinine looked better after stopping the lithium. Okay. There were some other uneventful visits in between that visit and this one. I guess by the beginning of 2022, he had an interval colonoscopy and endoscopy. He was diagnosed with Barrett's esophagus and was started on PPI, or his PPI was increased to twice a day. And then he had bad constipation and hemorrhoids seen on colonoscopy, and then he was just kind of having a routine follow-up with me at that point.
Do you mind if I break in here?
Absolutely.
So on this patient, we had genetic testing, the mood disorder genetic testing. Well, actually, I don't even know if we did, but I switched his PPI to second generation PPI.
I forgot about that.
Rabeprazole. And so he was able to take it I think he's still just taking it once a day, but he had much improved relief. I suspect he's a CYP2C19 rapid metabolizer. And so his body just was pushing through those PPIs, and they weren't staying in the stomach long enough to get the therapeutic effect. So there's a couple different medications, Dexilant, Rabeprazole, sometimes esomeprazole, that don't rely on the CYP2C19 enzyme for breakdown as heavily, and they can often be used. I think I even had to get a PA on a generic, but whatever, it happened.
Do what you gotta do.
Yeah.
Awesome. Thank you, Sue. Okay, so finally, May of 2022, we kind of have a come to Jesus moment with him and his partner and me in the room, and he finally acknowledges that his alcohol addiction was bad. He had been drinking for 30 plus years at that point. And he was even coming in to see me. He was having urinary incontinence, and I'm like, I think it's just because you're drunk. I did it, he was having some stool incontinence. And finally, I had mentioned not starting him on naltrexone several times, but he just was pretty resistant to it. And finally, at this visit, he was like, okay, let's do it. So Sue, the reason we're talking about this case and the integration of a pharmacist into primary care, he had a few visits with Sue here and there. I was the one primarily seeing him, but was the one, along with one of our previous physicians at Crossroad, that started our MAT program and then the Vivitrol naltrexone program at Crossroad. So they put together a whole protocol. I didn't do a ton of naltrexone in residency. I did a little bit, but they made it kind of dummy-proof, so I knew what to do. And started him on naltrexone on May 11th, 2022, and guess what? He stopped drinking. He saw Sue 2 weeks later, and generally try to get these patients that they're tolerating the PO naltrexone well to get them on Vivitrol, mostly for compliance. We like to see them every single month, making sure they're taking the medication, and also, you don't have to remember to take a pill every day, which is kind of nice. And he was sober for 2 weeks for the first time in 30 years. So it was pretty incredible. Still abstinent a month later. He looked like a totally new person. His skin looked a lot better. He was losing weight. Around this time, he came in for dizziness, and it was because he was hypotensive on all of his antihypertensives, so I took him off everything. I really think it was the alcohol driving most of it. His LFTs were better, reflex symptoms were better, triglyceride levels, his CKD had improved. It was just it was like, your gut's right saying that was the alcohol, but it's like that's a really hard behavior to change. So overall, he was feeling a lot better. His partner was thrilled because their relationship was a lot better with him quitting drinking, and said, let's follow up in a month. Okay, let me see. Okay. There were some visits here. He was coming in. We have protocols for nurse visits for patients to come in and they get their monthly Vivitrol injections as long as everything's stable. So he was probably on Vivitrol for like 9 months to a year at that point. And then he fell off. So I don't have like an amazing happy ending with him, but that's like the reality of the work that we do, unfortunately, at times. About a year later. Is that a year later? Yeah, almost a year later. Yeah, he had started drinking again and then was lost to follow-up. Basically what he had told me is he felt like he was in a good place. He had been sober for almost a year and just felt like he didn't need it anymore. So he stopped coming in for the injections, and then eventually came in and saw me and was like, I don't think I need this. I guess that was almost a year ago at this point. And you know what? We were hoping to have another update on him. He was supposed to have an appointment with us this week, but that didn't happen. But I would say I have seen so much success with naltrexone and Vivitrol, the integration of Sue helping out and having educational visits with patients, and then also having a BHC integrated into our care. They can have the ongoing therapy as well. So it takes a village. For sure, but his story isn't quite as happy as SH's, but I do think it illustrates the importance of having a pharmacist in a primary care office. And then also the other thing is that the Vivitrol is in general a very expensive medication, but we can get it very inexpensively through our 340B pharmacy. So I work in the Western Hills office. It's like about 20 minutes away from our OTR office that has a 340B pharmacy. So there's basically employees that work at all the different offices that will, get the Vivitrol prescription from the OTR office and bring it to the West office. So we just have it there. And then I think there's a financial benefit too.
Yeah, we make we generate about $300 additional dollars each time we fill a Vivitrol. And then it's 10 times that for the Hep C meds.
So anyway, and it makes it just care is accessible. It's not having to send, the Vivitrol to CVS and hope that, it gets covered and have the patient bring it to the office. There's still a lot of barriers to care with that. So just the setup we have that Sue put together has been really great. So I work in academics. I work with family medicine residents, and I tell all of them, you really need to work somewhere that has a pharmacist on staff. It gives me... first off, Sue and I have become good friends. She brought one with her. Even wonderful spiritual conversations.
I have
with
them
patients.
for everyone.
She gives out.
If they're having a hard time, I just say, can I give you a little Jesus? And it's
She gives
these
out
just
little
little Jesuses. Today I saw a patient I didn't even recognize in the office for a blood pressure follow-up. And I said, have I met you before? She's like, yeah, I've got your little Jesus right here. It's amazing. So I have one for everyone if you would like one.
And I have a little Jesus at my desk too, so yeah. So I think let's see.
It's reduced my burnout a ton.
Our emails are up here, so feel free to email us if you have any questions.
Yeah. Thank you, everybody.
Thank you.